Hello, dear colleagues. Hello. My name is Mynzhylky Berdikhojayev. My assistant, Shaykh Ahmed Mohammed Khan. And we have fellows, Rose from Philippines and Gitin from India. Our camera is there, yes. Okay. Maybe later you can see them. And also Enzo from Mongolia. Enzo is staying more than 2 weeks, huh? Yeah. For 3 weeks. He came for 3 weeks, okay. And yesterday we did one more case in the evening. It was a stenotic case, and it was a case number 5, and the patient number 6 we left for today because it was long day, it's Saturday, and all the team tired, and we decided to continue today on Sunday. This is only case scheduled for today, and patient has a petroclival small meningioma. I think this is a tumor blush, and on this image it looks like more than 2 centimeter tumor on the edge of temporal bone. And the patient has a trigeminal neuralgia. That's why it's an indication for the treatment in this case. Usually small meningiomas we are not touching, but in this case, yes, it's also possible to send her for gamma knife. We all the time discussing possible options, and patient decided to come for the endovascular treatment. The only branch going to this territory is meningeal trunk. I think the name is meningohypophyseal trunk, yes. Hypophyseal trunk, yes. And usually it's tortuous, quite short, and the navigation inside takes some time. I have seen possible options for this treatment. Professor Pedro Lilic showed Argentinian experience in dural fistula and meningioma tumors arising from the feeding with the ICA. It's possible to place flow diverter stent, yes, and then artery will close by the time. It's quite slow flow territory, and we did once for dural fistula. Patient came with the exophthalmos and red eyes, and we decided to place for the tentorial artery thread stent, and the dural fistula occluded. Yes. It's one of the possible options. Yeah? It's quite expensive treatment, but it's quite safe because the navigation in this territory not all the time easy. Nothing is easy in endovascular. It's just a matter of it depends on the instrument, it depends on experience, depends on angio machine, and if you have monoplane, you're limited by the imaging technologies. If you have no 3D, and then it's quite a problem to recognize the orifice of the artery. Yes. It's all the time some challenge. Huh? The life is challenge. The life is challenge. Женя, я буду включать 3D. Okay. Yesterday we made a 3D angiography. I asked Sheikh Ahmed to do this 3D angio. And this is a hypophyseal trunk. It's coming like this. There is a curve at the beginning, but I hope we can proceed with the Chikai 8 and the Sonic. But Sonic is 1.5 and it's a little bit stiffer than 1.2. It might be a little bit problem. It's challenge number 1. And the second challenge, we put patient under general anesthesia. We are planning to do balloon assistance with Eclipse. And I hope we can go there. It's a quite short segment, then there is some tortuosity. Usually we can see on PR yes, we can see the tumor. Okay, let's do it like this. This looks like spicum, and this is a tumor. You see, this territory is tumor territory, and okay, yes, here you can see there is a tumor. This one. I think it's growth. Comparing with the MR, this looks like bigger. Yes, that's why it's indication number 2. The growth of the tumor, neuralgia, and location. Yes, for this location, 2 centimeter tumor is quite big. Okay, we'll see the. Yesterday, Sheikh Ahmed made a angiography from all territories. The only feeder going to this tumor is this. At the end of the procedure, we will check again. Sometimes after occlusion of the main feeder, you can see additional feeders. But I hope this is a meningioma grade 1. And in meningioma grade 1, usually only feeder. Yes, not only, mostly it's a dural supply. Yesterday we have seen the meningioma supplying from the peel network. Usually it's an atypical meningioma, and the feeding is quite intensive in atypical meningioma. Yes, yesterday's patients, 5 patients, all okay, and we received all of them in the department, and now let's start this case. Yes, the patient is lady, quite young lady, 67 years old, 57, yes, 57 years old. She's quite young, even for Kazakhstan she's young. Huh? Yes, the life expectancy in Kazakhstan is 75 years nowadays. Nowadays it's 75 years. And I think in Japan, this is very young lady, yeah? In Japan. Because life expectancy in Japan is nearly 90 years, yes. And in Europe, she's a school lady, yeah? Yes. In Europe, the life expectancy is even longer than in Kazakhstan. I think in India, it should be nearly similar to Kazakhstan. And what about Philippines? Life expectancy? Late 60s, okay. It's nearly like in Kazakhstan. Huh? But in Mongolia, I think the same like in Philippines.
For women in Kazakhstan about 70. For men is like 65, something like that.
No. The mean life expectancy in Kazakhstan is 75. But it's a statistics, yes. There is a 3 lies: big lie, small lie, and statistic. Yes, I am joking, but it's alive. Yes, it's quite big meningioma. Now we are in ICA territory, and we can see there is a quite big meningioma. Okay. Назад. Stop. Осла. Okay. We have a good PCOM, you can see, and I hope we have a good ACOM. But PCOM is enough, and we can inflate our balloon. And I think the orifice of the artery is a little bit distal to this point. I will try to not touch the ophthalmic territory, but it's a little bit involved there. Okay. Oh, maybe a little bit distal. It's a problem of 15 balloon. Usually for stability from the beginning, it's better to use 30 millimeter balloon. A 30 millimeter balloon usually is stable from the beginning. And the balloon 15 millimeter in ICA usually playing like this, you need to stabilize like a horse riding. I'm inflating balloon with one hand and little bit keeping in tension with the second hand. Okay, let's check again. Maybe we occluded the orifice of the artery. Maybe. Let's see. Yes, the artery looks like there. Let's try to go. If it's not, then we can deflate the гепарин бересіз.
Гепарин. Без перевели.
Okay. Yes.
Без.
Береверсің. Yes, for this business, the better microcatheter is headway duo, but unfortunately yesterday we finished all stock of the headway duo, and that's quite a problem. Yes. Yes, with headway duo, it's very stable. You can use Chikai Black, and you can go with Chikai Black. But this is a Chikai. Yes, the other possible technique is sandwich technique. It's possible to place microcatheter here and compress with the flow diverter stent. Okay. The branch is coming somewhere here. Okay. Okay. Yes, CK8 is quite soft wire. Okay, let's try to do it like this. Sometimes it's helpful. Проводник телевизор. Okay. Let's see. Мына меткорға бере салу керек. Меткор. Мына биллион стикерін жабыстыра саласыз ғой? Okay, maybe we need to push a little bit our but balloon is a little bit forward. Okay. Он жетіге қоясыңшы кондиционер. Бақыт. Okay, nobody said it will be easy. It's all the time little challenge, huh? Okay. Сәл бір рет артық жасайсың. Еще раз. Стоп. I think it's also possible to infuse some chemotherapy drug from this point, and it's like in retinoblastoma cases. We already occluded the distal flow, and it's possible. Yes. Maybe for the future cases we can do it. Okay, it's look like this. Then I will pull a little bit more. Pull a little bit the balloon. Okay. It's not there. It's not so big branch, that's why it's a little bit problem. не бере салсаңшы. Х2 17.
Х2 17 versus.
Yes, unfortunately, it's finished all. Да, фингерик. Нужно будет погнуть под 90 градусов. Okay, we will try Х2 17. Maybe we can succeed with the Х2 17. Okay. Yes, if we could not succeed, then I can ask my colleagues Sheikh Ahmed and Marat to reject this meningioma. Yeah? It's option number 2. Последний раз. Было как раз. Барсик. На Соник гибрид палтыш. Стабрит крик. Был свобода. Yes, also we could induce thrombosis in this branch. Yeah? Yes, we have no real pro-integralin, tirofiban, that's why if we will decide to place stent, we should give it through the nasogastric tube. Yeah? Даже ыстық болып кеткен, да? Бақта ана вытяжной система, по-моему, вообще системиді ғой деймін? Вытяжной система. Общая система. Ана кондиционер 17-ге қой деп едім, что-то естімедіңіз ғой деймін. Отделениедағы кондерка келеді ғой. Yes, I think we gave a bit more curve, huh? Okay. Okay. Let's take Х2 17. Реально ыстық же или менсіз ба? Или реально ыстық па? It's hot here, yeah? Like in Philippines.
Hot? Is it hot here?
like in Goa. It's hot in the room. Беси.
Просто электрон был. Бүгін бітті ғой ораза. Ыстық шай ішіп алғам жаңағы рахаттан. Содан ысып тұрмайды.
От души, мало от души. Yes, and I forgot to congratulate. Today is Eid Mubarak for all Muslim people. It's a great day, and Sheikh Ahmed and other colleagues have fasted, and today is nice day. Huh? Okay. Balloon is little bit shrinked. Okay. Yes, the Chikai black is more stable wire. But, I think we can pull. We can push a little bit the balloon, and here is okay. I think we will inflate a little bit more to stabilize the wire at the orifice. Yes, with the headway door it's even more comfortable. Huh? Что это? Sounds good. It's not all the time possible to go, and we may come trans-circulation through the PCA, and it's also an option to come from above. Okay. It's not. I think it's not. Yes, we can try for another 30 minutes, and then we may stop. Huh? Stop. Okay. Okay. Yes, headway is quite stiff, and when you push it forward, then the whole system with the wire and the microcatheter is going forward. With headway do is less like this, and it's quite predictable, but not in the case of black. Okay, let's try like this. Yes, if not, we can give some ticagrelor on the table and trace the flow diverter and inject under the flow diverter a little bit squid 12 to occlude this part. Maybe we will do it. Okay, let's see. Oh. We'll see. We'll see. If you want to resect, then we can stop in 5 minutes. Agreed? She's agreed. If she is agreed, then we can stop. At some point we can stop. I think it's near the orifice of Okay, just a second. At this point, you can pull the balloon. Up. We'll inflate balloon more to stabilize it at the wall. And then let's try to push a little bit more. Yes. Balloon. I think it's stable. Okay, let's see. Yes, with headway do it's quite effective. Huh? Well, let's see how it is. Yes, let's look like this. All collaterals coming from external carotid. Yes, this territory is. You can see. Stop. Spirit. Now you can see. Spirit. Stop. There is a network coming from the external carotid territory, and they're giving collaterals something maybe here, yeah? It's coming like this, and the main trunk is going like this. I'm scary. Now we are in wedge position. The microcatheter is stuck at the orifice of artery. We can inject a little bit squid 12 and may finish from this point with a small risk of emboli. That's why the option number 2 to give ticagrelor and then place 27 microcatheter, and if there is some leak around the balloon, then we can open the stent. It's an option. Okay, let's see. We can inject. Наркоз поглубже. Дексаметазон готовый. Okay, we can inject a little bit, not so much. If we'll fill this segment with this small collateral, then we can finish. Yes, let's see. Yeah, later. I think it's a vein. It's a venous site. It's not a rupture, it's a venous site, and yes, maybe it's possible to go to the venous sinus and come from the venous site. I'm not sure. Okay, let's do it. It's not recommended to do it like this, but let's see. I would not recommend to do it like this if you have no experience with the liquid embolics. Yes. It's very important to have experience with liquid embolics, to know when to stop, and we are doing this in the case of CC fistula, carotid cavernous fistula. We are placing balloon and placing microcatheter and injecting liquid embolic from the microcatheter transarterially. Yes. Oops. Please help me, and I will overinflate my balloon. But it's not 100% safety. Yeah? Okay, there is a symptom, the balloon movement symptom. It's a symptom that liquid embolic is out of the feeder. Okay. Okay. I think now we filled also the collaterals territory. Yes, it's a collaterals. It's ECA territory, extracranial. That's okay. It's a meningeal artery.
Meningioma?
It looks like meningeal, yes. Okay, I think it's enough. Now we can induce something extra. It's no needed, huh?
Yeah.
Okay, then yes. Then we need to wait 5 minutes. If this liquid embolic look like on the balloon will start to move a little bit, then I will ask for flow diverter stent, and we can place the flow diverter stent. We can give heparin, and then we can place something like Derivo, Silk Vista. The guiding catheter is 8 French, and now we occluded branches from meningeal and from ICA. Okay. This looks like middle meningeal. We occluded the beginning part of middle meningeal. Последний суперселективный хорошо. Yes, this is a meningeal artery. Yes, it's a meningeal. And also we occluded small part of maxillary. The possible problem is oculomotor nerves feeding from these small meningeal arteries also. Let's see. Okay, timer reversal. Just a second. When we're injecting something liquid, then we need to place navigate. To see the possible emboli territory. I think it's all inside the artery. It's a balloon. Yes. Till now everything is in place. Yes. There is no emboli, and it looks like everything is stable. Nothing inside the ICA. Okay, I'm keeping the roadmap. After angiography, we can check again. Yes, on the roadmap, nothing is moved. It's a good sign. Yes, the MC territory is clear. That's a good sign. Okay. Yes, that's good. Do you see the tumor? No tumor. Okay, let's do it from the common carotid. Yes, the only problem, liquid embolic materials is not penetrating the small, tiny arterioles. There is a limit in volume, in the size of targeted vessels. Yes. It's through the collaterals. Yes. We have seen the collaterals at the beginning on the superselective angio, and it's networked between. It's just before the tumor. This artery has a collateral from the external carotid. Period. Okay, the brain is clear. Period. Yes, on venous face, everything is gray. Yeah. If you see some part white, there is a meaning some artery is missing. Yes, it's a principle of perfusion. Yes, 2D perfusion. Yes, but here everything is. It's the same things. Okay, let's do control CT, and then we can finish. 5 seconds is enough. Yes, we didn't check the vertebrobasilar system because PCA is supplying the territory. Okay. Dear colleagues, let's see the. Okay, I think it's like this. Like this. And okay, this is a tumor with contrast. And let's do new. I think it's here something. 500 soft tissue. Okay. Yes, thank you for Alberto. He showed how to use the system. Yes. Yes, this is a liquid embolic here in the meningeal branches, and the tumor with the contrast. And tomorrow we can do control MR, and we can show you how much is occluded. It's occluded just before the tumor. Okay, let's see. Let's see. This is a territory of ECA and the ICA. This branch is not visible. There is no branches for the tumor from the internal circulation. Okay. Let's look from here. This was collaterals. It came from here, and this bifurcation is then going to the tumor. This is branch came from middle meningeal artery. Okay. Let's see the sculpture of. It's like this, and then. Okay. Может быть обычный экран, обычный экран. Just a second. Okay, let's compare the images. This part is this part, yes? And this part is this part. And then there is a collaterals came from here. And we don't see the distal part. That part after this bifurcation is not visible, but it's occluded. Okay, we occluded this part. I hope the whole meningioma is now avascular. Okay, let's see. Control MR will show how much tumor territory we excluded. And let's see, this is a meningeal artery, and I hope we didn't touch cranial nerves circulation. Okay. Okay. Just a second. Let's check the eyes. Yes, it's symmetric, and after extubation we can check. Okay. Нажимам just Okay. Let's see. Okay, dear colleagues, Rose, Enzo, Gitin, come. Yeah. Cap and mask. Yeah. Okay, I want to introduce you to our international doctors. Gitin from India. Enzo, you have seen for previous 2 weeks, 3 weeks. Yes, and Rose from Philippines. Видно же, да, Жень? Okay. And also Evgeny. Пойдемте, Жень. Evgeny is our video support team. Head of the video support team. Видно, да? Okay. And Shey Ahmed. Okay. Eid Mubarak, and have a nice weekend. See you next Saturday. I hope so to see you on next Saturday. Have a good day.